I'm Guillermo Umperrez. I'm a professor of medicine at Emory University School of Medicine in Atlanta, Georgia. And I'm the president-elect of the American Diabetes Association. Today, I have the pleasure to discuss with you a 21st century challenge that is prevention of diabetes. The agenda for today's lecture includes global prevalence and projections of diabetes and pre-diabetes, recommendation for screening and diagnosis. What are the risk factors and pathogenesis? What drives this epidemic of pre-diabetes and diabetes prevention or intervention that have been shown successful, both lifestyle, pharmacological intervention, and even surgery? How can we prevent diabetes? This slide is taken from the Diabetes Atlas 9th edition, 2019. And they report a number of 463 million. And you can see it's here during the last 20 years, where we have gone from 151 to 3 times higher to 460. 1 in 11 adults around the world between the ages of 20 to 79 have diabetes. 1 in 2 adults with diabetes are undiagnosed. Unfortunately, half of the patients don't know that they have diabetes. 1 in 13 adults have impaired glucose tolerance, and the number is impressive, 374 million, knowing that these patients are at high risk to progress to diabetes. 3 in 4, so 79% of people with diabetes, unfortunately come from low and middle income countries, and that produces a tremendous burden in their healthcare. 10% of the global health expenditure spent on diabetes care. In the United States, it's $1 in $7 that we spend on diabetes care. And this is some information that I got from the IDF Atlas 9th edition. The country with the largest number of patients with diabetes is China, and India, with more than 75 million, is number 2. 1 in 6 people with diabetes in the world come from India. In this atlas, the projection is that it's going to increase to 134 million in the next 25 years. And there are several editorials, for example, Dr. Mohan, talking about the pre-diabetes and diabetes in India. He quote, that in addition to diabetes, pre-diabetes is a tremendous burden. And if we target them on the right lifestyle option to keep blood sugars, lipid, and blood pressure under control, diabetes can be prevented in 1/3 of the individuals in India. And this quote is not only for India, it's for the whole world. This slide shows the number of adults with diabetes between the ages of 20 to 79 worldwide and the worldwide projections. In the right upper corner, you have the current number of patients with diabetes, 463, and is expected to increase to almost 600 million in the next 10 years, and about 700 million in the next 25 years. We need to do something to prevent this tremendous epidemic. And if you look around, it is everywhere that is going to be increased. In the United States, in North America, they would expect to have 33%. In Europe, 15%. But look at the rest of the world of countries who have low income or middle income. In South America, the increase is 55%. Look at Africa, we're expected to have 143%. In the Middle East and North Africa, close to 100% increase. Definitive, we need to do something. In the Southeast Asia, as we discussed before, there will be close to 75%, where 88 million will go up to over 150 million with diabetes. This is a true epidemic of the 21st century. Just to emphasize what I mentioned before, the lower and middle and upper middle income, this is where you see the number of people with diabetes and what is projected according to age. In the United States, we have the CDC has been publishing this data every year, every 2 years. And what I'm presenting to you is the trends of diabetes diagnosis. And this is quite impressive. Let me show you this in more detail, this slide. In the left hand, you have the number of states, the 50 states in the United States, and the percentage of people with diabetes. And there was about 5%. Right now, we have a state that is more than 9%. And look at this, the number of states, especially in the South, there's still some states that have less than 9%, but all over, the increase has been dramatic. My state is Georgia. I live in Atlanta, it's located here. And it's in the middle of what we call the diabetes belt. With 11.7% in the Southeast have diabetes, compared to the rest of the country that is 8.5%. So unfortunately, the rate of diabetes that is associated with obesity, hypertension, stroke, heart attack is significantly higher in the Southeast in the United States. And there is no question that the driver is obesity. And again, data from the Center for Disease Control, or CDCs in the United States, that track obesity and present this data on a year or every other year data. And you see from 1990 to the left, the obesity rate, where very few countries, very few states have greater than 15%. Now, we have been innovated. The green color, the blue color have disappeared. And we have created new colors. We go from orange to 25 to 30%, 30 to 40, 35% in pink, and in the purple, 35%. Currently, 40% of African Americans, females, are obese. And we're expecting to have the whole country going to have 1 in 2 are going to be obese in the next 10 years. So we need, if we want to prevent diabetes, this would be the main focus, is prevention of obesity, because it's the driver for diabetes and prediabetes. This slide shows the prevalence of diabetes and prediabetes. And in our country, about 8.1% are undiagnosed. And here you have diagnosed with diabetes. This is data from 2000, a few years ago, on prediabetes. And you have 37%. The data from last year from the CDC says that we have 88 million people with prediabetes. But only 11% know that they have prediabetes. So 9 in 10 adults who have prediabetes are not aware. So we need to increase screening to alert patients or alert individuals that they can prevent diabetes if we implement new strategies. The other thing that is important when you read this epidemiological data is, how do you diagnose diabetes? If you use hemoglobin A1C for the diagnosis of prediabetes between 5.7 to 6.4, and we'll see in the next slide, you have about 34% of the population. But if you combine plasma glucose and A1C, it's 10.5%. I believe that we need diabetes and prediabetes is a disease of blood glucose, so combining plasma glucose and hemoglobin A1C is the ideal way to diagnose diabetes. So prediabetes is defined by the International World Association and by the American Diabetes Association in 2 ways. You can have an impaired fasting glucose. This is glucose between 100 to 125. Remember that diagnosis of diabetes is a fasting blood glucose greater than 126. So, and the hemoglobin A1C between 5.7 and 6.4. Remember, diagnosis of diabetes is a hemoglobin A1C equal greater than 6.5%. So why do we care? Because these also, same as impaired glucose tolerance, are at risk of developing diabetes. Impaired glucose tolerance is defined as a 2-hour plasma glucose between 140 and 199. And a hemoglobin A1C similar to 5.7 to 6.4%. Both are equally important. So the difference is that this is a fasting plasma glucose, and this is what we want, to get a fasting plasma glucose less than 100, the hemoglobin A1C less than 5.7. And if you do an oral glucose tolerance test, that is perhaps the best test, but is seldom done, you look for the 2-hour plasma glucose between 140 to 199. And why do we care? It's because of the large progression of diabetes. And if you look at the prevalence, what do you have? Impaired glucose tolerance is 51%, impaired fasting glucose about 1/4, and impaired fasting glucose and impaired glucose tolerance is 1/4. If you look at the progression, this group here of impaired fasting glucose and impaired glucose tolerance progress more than diabetes and impaired fasting glucose and impaired glucose tolerance. So keep that in mind. If you have a patient with a glucose between 100 to 125 and the 2 hours or a glucose tolerance test between 140 and 199, this is the higher risk of patients who will progress to diabetes. When you talk about risk factors, there's no question there are two factors that are quite important. One is your body weight, and the other is your physical activity. So overweight, 89% of patients who have diabetes and prediabetes are overweight or obese. 90%, 9 out of 10. 27% are overweight, 45% are obese, so if BMI greater than 30, and 15% have extreme obesity. Physical inactivity. Unfortunately, we don't move anymore. That's why we struggle to do exercise on a regular basis. And about 40% of people with diabetes and prediabetes are physically inactive, defined as with getting less than 10 minutes a week of moderate or vigorous exercise. Less than 10 minutes a week. And of course, obesity, especially abdominal obesity, is the one that drives the epidemic. And of course, there are some areas, like in South Asia, you don't have to be greater than 25. That's why you increase overweight when you're 23. And the rate goes with abdominal obesity. And why is that? It's because intra-abdominal obesity is an active metabolic tissue. And it recalls or collects their migration of macrophages, monocytes that convert to macrophages, and they produce several what we call adipokines. And these adipokines, like adiponectin resistant, free fatty acid, 2 necrosis factor alpha, and many others, are the ones who produce the insulin resistance and the decline of beta cell function. Because they are producing inflammation and reactive oxygen species that they decrease both insulin secretion and the response to insulin in peripheral tissues. So when you look at the beta cell mass, insulin deficiency is the most important reason why people develop diabetes. Here you have in patients who have diabetes to the right, impaired fasting glucose in the middle, and normal glucose tolerance test. With progression, it's a progressive disease, it's progressive disorder. When the beta cell mass, so the amount of insulin secretion, decreases both in impaired glucose tolerance and patients with type 2 diabetes. And the insulin resistance is associated but also with insulin resistance. The insulin secretion and insulin resistance go in parallel. So if you have patients with impaired glucose tolerance here to the left and diabetes to the right, what I'm trying to show you is the insulin action and insulin secretion. There is an impaired insulin secretion, but more importantly, there is an impaired insulin resistance. The insulin sensitivity, or the ability to insulin to dispose glucose in peripheral tissues, is present both in impaired glucose tolerance and, of course, in type 2 diabetes. So who should be screened? If we know that obesity and increase in age, the current recommendation from the American Diabetes Association will recommend that everybody over the age of 45 should be screened. It could be with the fasting blood glucose, or it can be with hemoglobin A1C. And in those patients that you highly suspect, you should consider doing an oral glucose tolerance test. Everybody who is overweight, so 25 for Western and 23 for Asian Americans, with one additional risk factor to be tested. And if your test is normal, you have to be repeated 3 years later. Additional risk factor will include physical inactivity, but we said, unfortunately, 10% of people with diabetes and prediabetes do regular exercise. Subjects with first-degree relative of diabetes. Minorities populations. Hypertension is a significant risk factor because it's associated with obesity and insulin resistance. HDL, less than 35. As we mentioned before, prediabetes, or anybody who has a history of cardiovascular disease, stroke, heart attack, or polycystic ovarian disease should be tested. Not included in here is anybody that also have a history of gestational diabetes should be tested, not only after the pregnancy, but regularly thereafter. How can we prevent it? There are 3 legs in this. First is lifestyle intervention, pharmacological intervention, and metabolic surgery. So, lifestyle intervention, there are 3 large studies that I'm quoting here in this table. Diabetes prevention in the United States and Finland and China. And here is the number, and the BMI in this group was very different. In the United States was 34%, Europe 31%, and in India and China was just 26%. The intervention period was between 3 to 6 years, and the reduction of going from pre-diabetes progressing to diabetes was very similar, somewhere between 40 to 60%. And the number needed to treat was between 20 to 30. So a very, very productive intervention if we can do this. So the diabetes prevention program, the goal was to decrease body weight for 5 to 10% in overweight people with pre-diabetes, doing regular exercise and diet. And the regular exercise was about 30 minutes a day. And what they reported is a 58% reduction. And this diabetes prevention program in the United States included a lifestyle intervention, so diet and exercise. They included metformin and a placebo, just regular activities. And what they reported is a significant reduction in the rate to progression from pre-diabetes to diabetes. In the lifestyle intervention, they observed a 58% reduction in the progression. Those with metformin, 850 milligrams twice daily by 30%, shows significant difference from the placebo group. And here you have this by age. And I think this is quite important in the way that age was a significant factor. Look at here to your right, those individuals who have over the age of 60 has the major benefit of lifestyle intervention. Likely, you are not going to be able, you have to be in good shape to be able to do regular exercise, that's right. So this is a selection. So for a patient over the age of 60, lifestyle intervention should be a prime. Walking 30 minutes a day about and following a diet to produce a weight loss about 5 to 10% of body weight. In the middle are those between 40 to 60, and here to the left, 25 to 64, where metformin was a little better than lifestyle intervention. That doesn't mean that we don't have to push for lifestyle intervention at all ages, because the reduction was about 50% in all groups. The Finnish diabetes prevention studies followed these 522 patients with pre-diabetes, and again, an extensive, intensive intervention of lifestyle. And they reported a similar reduction in the prevention going from pre-diabetes to diabetes over 4 years of about 58%. And the Chinese prevention studies, similar, 65%. And they started with a lower BMI. So lifestyle have been shown to be extremely important. And here you have the long-term intervention, 23 years incidence of type 2 diabetes. So the benefit persists. There is a legacy effect. And how much weight do you need to lose to prevent diabetes? Well, ideal, 10% of body weight, but it's hard to achieve. But if you look at these slides, you don't really need to do this. Every pound counts, every kilo counts. And if you lose 5 kilos, the rate of diabetes is decreased by half. And if you lose 10 kilos, it's gone. If you more than 10 kilos, the new data would suggest you even have diabetes remission. Of course, you're going to have pre-diabetes remission if you lose more than 5 to 10%. So these are being, intensive, prospective, randomized controlled studies with a lot of resources. But what happens when you translate this type of intervention to the communities? And the Center for Disease Control in the United States is pushing for this National Diabetes Prevention Program that have a minimum of 16 sessions during the first 6 months. They meet every week. During the second month, they have monthly sessions. And after a year, maintain sessions to push for lifestyle intervention, diet and exercise. And what did they report? Well, it's successful. About 30% complete the 1 year. And the weight loss is somewhere around 6%, 5%. The average is going to be, about 3 to 4%. So it is very hard to maintain. And we have seen studies like in diabetes and pre-diabetes that people can lose weight, but unfortunately, long term, they regain the weight. So it is needed maybe to consider pharmacological intervention. So there are, as I mentioned, many trials that you see a reduction of 30 to 58% reduction with lifestyle. But medication have been shown every medicine for diabetes treatment works, except sulfonylureas, except insulin secretagogues. But of course, the problem is, when do you intervene with pharmacological intervention? This is what we'll discuss in the next couple of minutes. So the impact of lifestyle is great, but unfortunately, not everybody can lose weight. So here you go for metformin and 2.8 in the diabetes prevention program. There is a reduction of 31%. But here it is. Look at the middle is metformin, 850 milligrams twice a day. Was very effective, especially in the younger individuals. But you have to consider the side effects. The India Diabetes Prevention Program compared, different groups. One group was just control, the other was lifestyle intervention, the other was metformin, and the other the combination of lifestyle and metformin. And what they report is that both metformin and lifestyle intervention were quite effective compared to control in this group. They showed a reduction of 29% progression from pre-diabetes to diabetes with lifestyle, and a similar group with metformin and the combination of lifestyle and metformin. So what do we recommend to our patients? Is that we start with lifestyle intervention, but if that's not going to be effective, or you see that the glucose level is going up, or the hemoglobin A1C go from 5.7 to 6.1, well, consider metformin therapy. There's also some consideration from other agents like Adipose. We don't use much this in the United States due to gastrointestinal adverse events, but they show that they have good diabetes prevention. TCDs, rosiglitazone, it's not in the market anymore, but they reported in DREAM studies as 60%. And if you know these agents work same like pioglitazone with ACT now, they have even now a 70% reduction. But these agents have significant adverse events, like increased risk of fractures, increased body weight, edema, and worsening heart failure in some individuals. So, can you really use these agents for prevention of diabetes? Likely, I will have to think twice because of the benefit and con of adverse events of these agents. What about liraglutide? It's an expensive medicine, but a higher dose was shown to be very effective. Diabetes prevention, like shown here in blue, is liraglutide versus placebo because it produces a significant amount of weight loss. And the number of patients with prediabetes was significantly reduced. So these agents are effective, the same as the weight loss medications. And for example, in this study for Phentermine and Topiramate, there is one of the weight loss medications that is available in many countries. You see a significant reduction in the progression of prediabetes to diabetes and the rate of prediabetes. Why? It's because every agent that is associated with weight loss had a significant impact on prediabetes and diabetes conversion. This just shows that bariatric surgery also decreased the incidence of diabetes, of course, because of the weight loss. So far we can say the following. Obesity and inactivity are the two drivers on top of genetic background. So if every intervention that produces weight loss should decrease the rate of diabetes and prediabetes. But we have barriers, that's right. The uptake and adherence is very poor. In the United States, it's about 30% that complete the intervention after 1 year. But those who complete the intervention in real world have a significant reduction in diabetes conversion. The other is that most of these studies that shown tremendous impact and outcome are grants or fundings that are for a periods of time that go from 2 to 5 years. When the grant goes away, the intervention goes away, and most people produce weight gain. So we need to find a way to have a more persistent information, or more increase the adherence to all of this group of people. Remember, this is what happened, for example, in the DPP. In the lifestyle produced a tremendous weight loss in the first year or two, but unfortunately, after the year 5, when the study ended, they went back to very similar to control. But if you look at those who maintain therapy, for example, diet and lifestyle, and this is after 20 years, you see that they are very effective in the conversion of diabetes. And since 2018, and this is today in 2021, recommendations for the ADA standard of medical care, we recommend lifestyle intervention. But if a patient cannot do lifestyle, or glucose continues to increase, metformin could be considered for those with prediabetes, in those who have a BMI greater than 35, especially in the younger patients. You remember that the older benefit from lifestyle, but many patients over the age of 60 cannot do exercise, cannot do a regular diet, and they also benefit. Anybody who has a previous history of gestational diabetes, as we mentioned before, is at high risk of converting prediabetes to diabetes. And if I mentioned before, rise in hemoglobin A1C, rise in fasting plasma glucose is a red flag or a yellow flag telling you that perhaps you should consider metformin as an intervention. What about the rest of medicine? I don't think that in the short term they should be approved. Why? Because cost, adverse events. So, for example, thiazolidinedione, pioglitazone, they're very effective in preventing diabetes, more than 60% reduction. But they have a tremendous number of adverse events, so it shouldn't be used. GLP-1, but in the United States, these agents cost between $400 to $800 a month. With metformin, it's as effective, or maybe equally effective, but there's no comparison studies. But metformin is $2 a month. So I think that in the future, these recommendations that have been present from the ADA during the last 3 years is the way of the future. And I will highly recommend to start metformin in this group of patients that they cannot lose weight, cannot do exercise, or those patients who have significant adverse events. I will really thank you very much for the opportunity to share my thoughts and review the literature on diabetes prevention. The epidemic of the 21st century, also together with diabetes, is obesity. And we need to tackle both in order to prevent the conversion from pre-diabetes or going from normal to pre-diabetes to diabetes. Thank you.